So we thought it would be helpful to have a seminar about some recent advancements with our faculty, Dr. Coughlin and Dr. Long Gardner, and also talk about ways that we can help support you. And today's really going to be about discussion and interaction. So we encourage you to ask questions after each presentation if you have them. So I'm going to go ahead and turn it over to Lisa here, and then we can go ahead and get started.
Hi, I'm Lisa. I've met some of you. Nice to see you. I'm the clinical program coordinator for our center here. Wanted to welcome everybody again to this presentation. We are going to start with a presentation by one of our research coordinators, Michael Skipworth, who's going to be sharing about our current studies, what is open to recruitment, and seeing if you're interested in getting involved. After each of our presentations, we'll have some time for questions. So please save all your burning questions until the end. So with that, Michael, take it away.
So hello again. My name is Michael Skipworth. I'm one of the research coordinators here. I'll be a little bit louder. There you go. Hi, my name is Michael Skipworth. I'm one of the research coordinators here. I help run all of the PI-initiated studies here at the Parkinson's and Other Movement Disorders Center. We're just going to go over some of our research that we have here, some of our available and active enrolling studies, as well as what research is, how to get enrolled, and what participating means to both the Parkinson's community and to the research community. So some of the things we're going to talk about today is we're going to meet our UC San Diego Movement Disorder Research team. We're going to talk about how research happens and what to expect when you're participating in research. We're going to go over our active and enrolling studies here at UC San Diego. And then we're also going to do some minor research demos here for you, just so you can see what participating looks like for some of our research studies. So our research team consists of physicians or movement disorder neurologists, nurse practitioner, clinical research coordinators, regulatory coordinator, research manager, and some student research volunteers as well. Our enrolling studies can be found on both observational and therapeutic, which we'll go over in a little bit, can be found on our UCSD Parkinson's and Other Movement Disorders Center website, which I'll have some links for you later in the presentation, as well as a QR code, and we can go through that together. And then just to inform you, your primary contact when you're conducting a research study will be the research coordinator. So for most of these studies, it'll probably be me. But as you're going through, you'll engage with some of our movement disorders neurologists, but your primary contact will most likely be the research coordinator themselves. And then I'd like to note that we're going to be using study and trial kind of intermingled during this research presentation, but they are both the same thing as in terms of this presentation. Okay, so now we're going to go over why research happens and what to expect. Okay, but first, we're going to talk about why you participate in a research study. So there are very large reasons to participate, both personal and overall for the interest of research. But to quote the Michael J. Fox Foundation, every treatment that exists today is the direct result of individuals raising their hands to volunteer for research. So participating in research helps to both advance the scientific knowledge and aid in finding methods of diagnosis, prevention, effective treatments, and hopefully, as we all hope, a cure. It also helps you get first access to some of the newly developed treatments that we have. So those are clinical or therapeutic trials. These are the ones that provide medication to help prevent the progression of Parkinson's or to help mediate some symptoms for Parkinson's disease as well. You also get close monitoring by health professionals. So seeing our clinical neurologists can be very hard in the day-to-day clinical care, but if you participate in a research study, you get close monitoring by our neurology professors, and it helps to get a little bit more long-term tender care at the times that you're not able to see them clinically. You also learn a little bit more about your condition or you and your family members' condition. So we also have research studies that we'll go over later that involve family members who have family members who are diagnosed with Parkinson's. We also have research studies for healthy volunteers, so we can help get some information about non-Parkinsonian information as well, including blood pressure. Again, we'll go over those a little bit later. And then also this helps benefit future generations. So like we said, when you participate in research, it not only helps you currently, but it also helps future generations to get more information about this disease as well. Okay, so we're going to go over some different types of studies that we have here at UC San Diego. So not all studies test medications. Some we have observational studies, and then we have therapeutic or clinical trial studies. So observational studies, we're going to focus on collecting data or observing, and no experimental medication is given. Observational studies help us learn more about a disease or condition so that we can help develop hypotheses about potential causes, risk factors that can then be put to test in clinical trials. So this helps build the foundation of what our clinical trials are. Observational studies can find associations between things, but they can't prove one thing causes another. So remember, correlation does not equal causation. Observational studies are just as important as clinical trials to the advancement of scientific knowledge and towards the progression of finding a cure. So on the left-hand column, we have a few different types of observational studies. We're just going to go over those really quickly. A longitudinal study follows participants over a specified period of time. These studies are generally observational, but sometimes they can be experimental. A cross-sectional study captures data of many people across a particular moment of time. A case study or a case control study compares a group of people with a condition to those without it. And a case study specifically is a detailed description of one or more cases of that specific condition in patients. And then the last one on the left-hand column, a cohort study involves observing a large group of people at different times. So we have some of these that we'll be talking about later today. If you have any questions, again, please feel free to ask us when we have the questions section. Now, in the right-hand column, we have a few listed phases of clinical trials. So a clinical trial, also known as an interventional or a therapeutic study. In clinical trials, we test new ways to prevent, detect, or treat a disease. So specifically Parkinson's for the ones that we'll be talking about today. Treatments can be new medications, new surgical procedures, new devices, or new ways to just use existing treatments. So again, we're going to go over the ones in the right-hand column really quickly. On the right-hand side, so a phase 1 trial usually involves about less than or up to 100 participants. And the purpose is to find whether a new treatment or intervention is safe, well-tolerated, and to find the appropriate doses. Phase 2 trials, which are the trials that will most likely be held here at UC San Diego for movement disorders, usually involve 100 to 300 people. And here we're going to focus on the effectiveness, but also continue to study safety as well. Participants receiving this new intervention or a therapeutic treatment could also be compared to those receiving a different treatment or a placebo. So that could be different arms or comparing a placebo to getting the therapeutic treatment. A phase 3 trial could involve several hundred to thousands of participants. At this stage, we're going to gather information about safety and also determine if the benefits outweigh the risks. So if the results are positive, they're submitted to the FDA for approval to the market. And this is when we get the medications that are open and available to participants clinically. And then lastly, we have phase 4, and this involves thousands of participants, and these are what we call post-marketing studies. The treatment is monitored in large, diverse populations to get a full view of its safety and effectiveness. So these are all of our observational and therapeutic trials, but today we'll be going over mostly observational trials focused on Parkinson's. So if you have any questions, feel free again to ask them later. Okay, so what do we expect in research? So first off, we want to always remember that participation is voluntary in research. You should not be coerced or forced to participating. Everything is voluntary moving through research. You should always ask the researcher to provide you with a consent form or an ICF prior to your first appointment, which is called a screening visit. Review that consent with your partner, with your family, with your primary care provider, with your neurologist to help prepare to ask questions about the research, to make sure that you're well informed before enrolling, and to make sure that you have enough information as you're participating in the study as well. So the baseline visit or the second visit may also be called randomization. This is usually for any therapeutic trials that get a therapeutic medication, or for some studies that require randomization to help balance out the studies as well. Also remember that privacy protections also apply in research. So whenever you're signing a consent, you'll also be signing a HIPAA, which you most likely sign with your clinical professionals. Your information and your privacy is always protected in research as well. So if you have any questions about that, you can always talk to your coordinator or talk to the clinical care team associated with that study as well. So during a study or a research trial, it's imperative to follow the study guidelines. Specifically for therapeutic trials, they come with a protocol as well. And this protocol helps guide both the coordinators and the participants as you're going through the research study. So it's imperative to make sure that that data is clean, that data is appropriate, and it's also accurate to help provide the best information to that care team related to that therapeutic trial. Also remember to continue your usual medical care with your primary care team. So when you're participating in research, it helps to gather more information, about your condition or your family's condition, but this does not substitute your primary clinical care. So remember to continue your clinical care with your team as you're participating in the research study to make sure that you're getting that consistent care throughout the research study. And lastly, also remember that you can withdraw at any time. So as you're participating in research, again, it's voluntary. So whether that's 5 seconds after you sign the consent, 5 minutes, 5 years, 5 hours, 5 days, you can always withdraw at any time. Just let your neurologist know or let your coordinator that you're primary contact with know, and they will go through the process of removing you from the study as well. So now we're going to go over some general questions to ask. So asking questions can help you know what to expect when you're participating in a research study. You can ask questions at any time. Most likely at the screening visit is where they'll give you the most time to ask questions. But again, at any time, you can feel free to ask some questions. Here are some example questions to ask when you're inquiring about a study. So what will be expected of me? What will happen in a visit? How flexible is the study schedule? What are the potential risks? What are the potential benefits? How frequent are the study visits? And so many different other questions that you can ask your clinical care team and the research team as you're going through a research study. Many of these questions may be answered in that ICF or the informed consent form, and the answers to these questions are different per study, but definitely feel free to ask those questions whenever they pop up in your head. It may help to ask for a visit calculator to help project our future visits or ask what's allowed in the range of dates that are required for visits, because some research studies require a specific visit window that you have to have those dates. But again, ask your research coordinator or the primary neurologist on the study if you have any questions about that. And then it may be possible to participate in 2 different studies at once. I know those of you here who have participated in research have probably participated in a couple of studies at the same time. But you should definitely verify with both the research team on both studies to confirm that you're not going to be doing something that you're not supposed to be doing in terms of participating in 2 research studies. Okay, so now we're going to be talking about some of our active and enrolling studies here at UC San Diego. First, we're going to go over some of our atypical Parkinsonian and other studies. Most of these will not apply to you, but we're just going to go over them really quickly just so you guys can see what they look like and see the wide variety of research that we have here at UC San Diego. We have studies focusing on multiple system atrophy or MSA. We have some studies focused on progressive supranuclear palsy and corticobasal degeneration. We also have some studies focused on dementia with Lewy bodies. And then we also have, to highlight some of our non-atypical Parkinsonian studies, we also have 2 general movement disorder studies, our biological sample repository and our MDC database study. I want to highlight the Movement Disorder Center database study because this is a very minimal, very easy study that participants can take place in. It helps get information out to you as a research participant about upcoming studies as they're coming along. So if you're interested in participating in research, but you don't know what you want to do, or you have questions, or you just don't want to do it now, but you want to be contacted later, you can always feel free to sign up for our Movement Disorder Center database, and we can take that information, look through the medical records, and confirm if you're eligible for a study and send that information out to you. So again, if you want any other information about this, definitely feel free to talk to us. After this presentation, we can make sure to reach out to you and contact you about this. All right, so one of our first studies that we're going to go over is PPMI, or the Parkinson's Progression Marker Initiative. So the focus of this study is to assess progression of clinical features, digital outcomes, and imaging, biologic and genetic markers of PD progression in both study participants with the PD diagnosis, individuals with genetic mutations related to Parkinson's, and healthy controls as well. So if you don't want to participate by yourself, you can also ask a friend, a spouse, a care partner to also enroll in some of these studies as well with you, and we can go over that and how scheduling works as well. But what does study participation look like in this study? So for this study, it's an annual visit for a minimum of 5 years. They're going to do some biological samples collection that includes a blood draw, lumbar puncture, urine collection, and skin biopsy for this study. They're going to do some cognitive testing and questionnaires. They're going to look at physical and neurological assessments, kind of related to what you receive in clinical care, but these will be separate from your medical records and attached, again, only to the research study. And then they're also going to do some brain imaging scans for this study as well. Please note for this study as well, there's potential travel reimbursements if you don't live locally or if you are traveling to different sites. Some of our research studies do have travel reimbursement, but again, please talk to your primary contact, which will be your clinical coordinator, about if your study actually has any travel reimbursements. So next, we're going to talk about the Dementia with Lewy Bodies Consortium. And I know that you're asking, this is a Parkinson's study and talk. Why are we talking about dementia with Lewy bodies? Well, this study is also looking at participants who have Parkinson's and are showing maybe a little bit of cognitive issues. So as you can see, the Lewy body dementia umbrella is what we're looking at when we're participating in this Dementia with Lewy Bodies Consortium. So if you or anybody that you know it has Parkinson's disease and has any memory, thinking problems, any issues with spatial awareness, definitely feel free to contact us because they would still be able to participate in the study even if they don't have dementia with Lewy bodies. The purpose of this study is to develop a collection of subjects, again, Parkinson's and dementia with Lewy bodies, who will be followed over a period of 5 years with detailed clinical information, collection of specimens, imaging data, and to promote additional future research in both of these diagnoses, including therapeutic trials by having readily available subject samples. Again, biological samples and clinical samples both help to push research towards the end goal of finding a cure, and some of this research is taken over the course of a longitudinal time. So what does participation look like in this study? Again, it's an annual visit. This one is up to 10 years. Participants and care partners are interviewed with study staff. So we will put you in separate rooms and ask you both separately about what the clinical care and what your daily life looks like, just so we can get an overall picture of what it looks like to have your daily life. We're going to do some biological samples collection. Again, we're going to do a blood draw, a lumbar puncture, which is optional for this study. They're going to do some cognitive testing and questionnaires, which you will see across many of these studies. We're going to do some brain imaging scans. And then again, for this study as well, there is a potential for travel reimbursement if you want to travel from out of state or from out of the city. Now we're going to get into some of our PI-initiated studies or studies started up by our clinical care team here at UCSD. This one is called the Multimodal Monitoring System to Help Determine Falls. We call this the Fall Meter Study. This study is attempting to create and validate an unobtrusive multimodal monitoring system that can be used at home by patients with Parkinson's disease and other various movement disorders to help understand what the potential risks are when falling. This study participation includes 3 visits, so a screening visit, visit 2, and visit 3. In the screening visit, we're going to be consenting and collecting demographics. We're going to be collecting medical history and medications. We're going to be doing a physical and neurological assessments and exams. We're also going to be doing a Parkinson's rating scale, which you will probably do with your clinical care team when you go visit your neurologist. And then at the second and third visits, they're the same visit, but they are slightly different in the way that we're going to be running them. So we're going to be doing walking and balance tests while wearing different devices, and we're going to be doing these while you're on and off medication. Again, we'll talk about this when we're at the screening visit about what that means and what the timeline would look like. But we're going to be doing this so we can see whether your medications also play an influence in predicting falls. We're going to be doing these walking and balancing tests while you're wearing the following devices. We're going to be wearing motion sensors that we're going to put around your waist, your chest, your arms, your legs. We're going to be taking your blood pressure while wearing a caretaker, a blood pressure monitor that continuously measures your blood pressure. We're going to have a wireless ECG monitor so we can measure your heart as we're going through this as well. We're also having EEG, that's misspelled, an EEG monitoring system as well, so we can look at your brain while you're doing these falls. And we're also going to be having you wear what's called new shoe technology, which we'll demo a little bit later, which is a shoe that will have you wear that will vibrate when we potentially think that you're going to fall, so we can see if we can catch those falls as well. We're also going to be collecting your blood pressure measurements while you're lying and standing, just so we can see if there's any drop in blood pressure, if that might be contributing to your falls. And we're also going to be doing an optional video recording as well, because this helps us capture data on what it looks like when you're preparing to catch yourself, when you might be experiencing a potential fall, or when you're just walking normally, so we can see and notice these issues. And then we're also going to collect a small survey about your activities of daily living and what it's like normally if you have any falls, if you have any issues with medication, and what that timing looks like. Now we're going to be talking about one of our other PI-initiated studies, the real-time microneedle study. This study, the purpose is to evaluate levodopa sensing devices and safety in both healthy subjects and Parkinson's subjects. We're going to compare the levodopa levels measured in the biosensors to levodopa collected in plasma using a blood draw to help validate these devices in PD patients and help determine the acceptability of these devices. So do they feel suitable to use for daily life, or if there are ways that we can improve them? Study participation for this study includes 2 visits, a screening visit and a baseline. And again, at the screening visit, it's approximately 2 hours, but we're going to be doing the same thing we will hear multiple times today: consenting, collecting demographics, collecting medical history and medications, physical neuro exam, MDSU PDRS rating scale. This one has a baseline cognitive exam as well, just for inclusion and exclusion into the study. Now, the big meaty part is the baseline of the study. So this baseline visit is about 4.5 hours, and you'll see why it takes so long. We'll be doing sensor measurements, sweat, blood capillary, or microneedle. Currently, we're doing the sweat and the microneedle measurements together, but you'll see what those look like as you participate in the research study. We'll also be doing some Parkinson scale measurements as well, so we can see as the levodopa is entering and leaving your system, what those Parkinson's measurements look like. So you can see as we're going through with the neurologist what that level looks like as you're getting those medications in. And we're also going to be asking you, how acceptable are these devices? Do they feel okay? Do they not feel okay? Which ways we can improve them so you can use them for your daily life? We actually had a CNN episode on the devices that we have here, and I'm just going to play a small little clip for you, but I also have the full episode online if you want to look at it with your QR code, but we can also go through this later. But I'll just play a small section of that episode for you so you can see what it looks like. This is a little slow, a little low, maybe. Okay, maybe not, because it's a little bit quiet. But this little section of the CNN episode talks about how these devices are needed by patients who have Parkinson's, how getting these devices can help with understanding the levels of medication in your system when you're feeling on or when you're feeling off. These terms might be familiar to some of you from hearing them from your neurologist. About feeling if those symptoms might be related to the level of medication and helping us to determine what the right levels of medication are using sensor-based technology. This next study that we have right here is another PI-initiated study. So it's the effects of blood pressure on cognition in Parkinson's disease. The purpose of this study is to determine how blood pressure, or BP, relates to cognition during the supine and upright cognitive testing. So we're going to test and see how your blood pressure affects your memory and thinking while you're lying down, while you're standing up. This determines how the oxygenation in your brain, or your brain getting enough oxygen, correlates with thinking and blood pressure when you're in these different positions. And we're also going to try to explore the longitudinal association with this. So not just seeing if it affects your memory and thinking immediately, but also if lying down and standing up over the course of 2 years, does that affect your memory? Does that affect your thinking? The study participation includes a screening visit, a baseline visit, and then a 2-year follow-up visit for this study. For the screening visit, again, like you've heard many times today, consenting, demographics, medical history. And this one, as you can see shaking up there, we're also going to do a tilt table blood pressure measurement. We'll show you what that looks like today. We're also going to be doing a physical neurological exam, Parkinson's rating scale. We're going to do a baseline cognitive exam as well, just to determine what your baseline cognition is at screening. So that way, if anything changes from the screening visit to the baseline visit, or the screening visit, baseline visit to the 2-year follow-up, we can get those measurements and have that accurate data. And then what the baseline and the 24-month follow-up visits look like. So this is 4 sessions of cognitive testing with the following devices. So we'll have the caretaker blood pressure monitor, which you've seen earlier in a different study, that will be continuously taking your blood pressure while you are in this lying and standing position. We will also have a oscillometric BP monitoring device, or the one that takes your blood pressure when you're with your clinical care team, and be taking them with both devices so that we can ensure that we get an accurate measurement of your blood pressure in these different positions. And then, as you can see blinking there, we're also going to use what's called a functional near-infrared spectroscopy, or an FNIRS cap. This cap is, we've been told that it looks like kind of like a Frankenstein cap, because it is a cap that has little sensors and probes on it that shine a red light inside of your skull, and they help read the brain blood flow while we're doing different cognitive tasks. So while you're lying and standing, we're taking your blood pressure, and we're also looking at your memory and thinking and your brain blood flow during these different tasks. Again, it's 4 sessions, so you'll do this lying down, standing up, lying down, standing up. And then we're going to look at these measurements over the course of that baseline visit, and then 2 years later as well, to see if there's any difference, both in the blood pressure, in the memory and thinking, and also in the brain blood flow. That's just about it for all of our current enrolling studies. I will slightly move this out of the way because this is kind of blocking our section. There we go. If you want to learn any more about some of these studies, you can use the QR code. We also have some of our flyers available as well at front if you want some of those. But you can also find all this information at the movement disorders site that you can see up there. So movementdisorders.ucsd.edu. If you have any questions, any information that you want more about specific studies, feel free to ask anybody on our research team. You can feel free to ask me. I will be the one that will probably be contacting you for most of these studies. But again, if you have any questions, please feel free to contact me. Now we're going to do some very minor research demos, nothing too big, mostly because our devices are very fragile and very expensive, so we don't want to make sure that they are being passed around too much. But I will go up to the front and show you some of our technology that we have here today. So we're going to do the new shoe, and we can kind of pass that around while we're doing different presentations because it's a shoe. And I'll also show you, I'll get on the tilt table, so nobody actually here has to get on the tilt table. But we'll also show you what the tilt table looks like when you're going in that lying and standing position, so you can see what that final study looks like. Okay, perfect. I will grab the shoes and I'll pass them around. If you guys want to pass the shoes around, you can just pass one shoe around at the time. They're basically the same. And then I'll be in the front right here, and I'll show you what that looks like.
Did anyone have any questions for Michael? You were so thorough. What was that?
Yeah, so with the new shoe, it vibrates when you're holding it. Sometimes it vibrates at random intervals because you're not actually wearing the shoe right now. But what the shoe does is it helps to both measure when you have any falls, but also understand that if you're falling, it'll vibrate and it'll help you correct the positioning of your falls to help recover a little bit easier. If you want more information on kind of how that works and how that works within the research study, I can definitely answer any questions that you guys have. But yeah, so it'll vibrate at random intervals. It'll be a little bit easier when you're wearing the shoe because it doesn't just randomly vibrate. But if you have any questions about any of the research studies or any of the devices, feel free to ask me before we do any of the demos. So, are there any questions? Yeah. Skipworth, Skipworth.
And where do you contact by email or phone?
Either one works well for me. I also have some business cards at the front. You can contact me by phone or by email. Email will probably be a little bit easier in terms of contacting back, just because if I'm downstairs with a patient or I'm in the clinic or not near my phone, I can respond to that email with my phone. But if you leave a voicemail, I'll definitely call you back as well. So whatever is preferred contact for you, we can definitely follow up that same way as well. Oh, so our business cards will be outside when they're with our flyers and everything for research as well. Yeah.
Are any experimental medications involved?
For these studies, no, there are no experimental medications. We're hoping to get some therapeutic studies that include experimental medications in the coming year, and we'll definitely send that information out to participants that might be interested when that information comes out. But all of these studies don't require any additional or experimental medications. Any other questions? No, so when you participate in research, you shouldn't have to pay for anything at all. Parking is covered when you come here for our research visits, and some of these studies are also compensated, but you should not have to pay anything when you're participating in research as well.
Not related to Parkinson, what movement disorders are you speaking about?
So those are the ones that were at the beginning of the slide, the atypical Parkinson study. So we have multiple system atrophy, progressive supranuclear palsy or PSP, cortical-basal degeneration or CBD or CBS, and then we also have dementia with Lewy bodies or DLB. Those are the main studies that we have, but we also have some additional studies that aren't covered on here. If you want to know any more about those or if any specific conditions, definitely feel free to reach out and contact us and we can send that relevant information out to you as well. That would be a good question to ask your coordinator. So if you, what I tell participants when they're contacting me is, what is the thing that you want to know most about yourself when you're participating in research? So if you want to know more about your memory and thinking, you want to know more about how medications interact with you, if you want to know more about how what's causing falls, that would be a good way to participate because there are most likely other people that also want to have the answers to those questions. And if you're able to provide those answers by participating, that's the best way to kind of move forward. But it's really up to you about what you want to participate in. If it's everything, one thing a year, it really just depends on what is best for your schedule.
So of the studies that you've shown, what studies can you multiple sign up for?
So for all of our PI-initiated studies, actually, you can sign up for all of them. Most of them also will transfer some of the medical history and medications forms. So the more you sign up, the easier it is to kind of transfer that information over as well.
Conditions that would exclude you from these studies?
Again, that depends on each individual study. For most of them, they are any major medical conditions that might impair measurements for those specific studies. So for example, for the blood pressure effects on cognition, if you have DBS, that would affect some of the measurements for the study. If you're not taking the correct medications required for the study, or if you're taking medications that aren't allowed for that study. Again, it just really depends, but if you reach out with the study that you're interested in, we can definitely send that information out to you specifically. Is there anything else?
since these studies go on for a number of years, is there any age restriction?
For most of these studies, they don't have any age restrictions. They have a age minimum. But again, it just really depends on the study. I don't think any of our PI initiated studies, the studies covered today, have any age restrictions on them. It's mostly when you're enrolling during that screening visit, that will be the age that's most important. So if you enroll at 79, but the cutoff is 80, because you enrolled at 79, you're still able to participate in that study even when you turn 80. That age cap is mostly just for inclusion into the study. It's not for participation all the way through the study. Any other last questions?
And we'll be time at the very end for questions.
Okay, perfect. And then I'll save the demo for Dr. Longarder's presentation because it will correlate with that as well. But thank you for listening to me today.
Can I have my notes on one of them? No presenter view. If not, I'll just grab my laptop if that's okay.
Sure. We're just gonna get some notes for Dr. Longardner. Mhm. That, the beginning, okay.
And then we're gonna put this.
Sorry about that.
Okay, can everyone hear me? Okay, hi. Thank you all for being here. I'm Katie Longardner. I'm a movement disorders neurologist and clinical researcher. I'm going to talk more about the research projects that I'm involved in. Michael already gave you a brief whirlwind of a tour of most of these. I'm going to go into a little bit more detail in terms of why we're doing this research and some of our preliminary data. These are my disclosures. So my personal research focus as it pertains to Parkinson's disease is related to improving diagnosis and management of non-motor symptoms. I'll talk more about what that means in a minute. And using non-invasive wearable sensor technology to improve diagnosis and symptom management in people with Parkinson's disease and other movement disorders. So non-motor symptoms, just briefly, if you've never heard this term, these are symptoms from Parkinson's disease that affect body systems other than movement. And they're often as disabling or even more disabling or problematic than motor symptoms. So if we think about motor symptoms being what people can see on the outside, that's really just the tip of the iceberg. And non-motor symptoms in Parkinson's disease involve things like sleep, mood, cognition, behavior, and also autonomic system. So the autonomic nervous system is the network of nerve cells throughout the body that controls your automatic functions, things like urinary and sexual function, constipation, stomach emptying, and also blood pressure control. And so my research focuses on this dysregulation of blood pressure that can happen in Parkinson's disease. So orthostatic hypotension is what we call low blood pressure on standing. This is defined as a drop in blood pressure of at least 20 millimeters of mercury systolic, that's the top number, or 10 millimeters of mercury diastolic, that's the bottom number of the blood pressure, that occurs within 3 minutes of standing up or head up tilt. And this can happen years or even decades before the motor symptoms of Parkinson's disease start. Can happen at any point throughout the disease stage and occurs in about 1/3 to 1/2 of people with Parkinson's disease. This is important because regardless of whether people experience symptoms from low blood pressure, which might include things like lightheadedness, dizziness, feeling faint or foggy when you stand up, it's associated with worse health outcomes, including falls, hospital visits, and cognitive impairment. So cognitive impairment or trouble thinking is also very common in Parkinson's disease. It increases the longer you live with Parkinson's disease, and this contributes to disability, caregiver burden, placement in residential facilities, and health-related costs. And while there's no cure for cognitive impairment in Parkinson's disease, there are medicines and other things that can help treat the symptoms. I'm interested in this connection between orthostatic hypotension and cognitive impairment because I think that low blood pressure could be a treatable risk factor for cognitive impairment in Parkinson's disease. There's a very strong association between low blood pressure when standing and cognitive impairment in Parkinson's disease, with studies showing that people that have orthostatic hypotension perform worse when they're standing up on cognitive tests compared to laying down or sitting up. And that can happen even when they don't have any symptoms of low blood pressure. There's also large cohort studies across various stages of Parkinson's disease that show a strong association in the long term, again, between orthostatic hypotension and cognitive impairment, with the recent meta-analysis of 18 studies showing that the odds of having mild cognitive impairment if you have orthostatic hypotension in Parkinson's disease is 1.8 times greater, and the odds of having dementia is over 4 times greater. And this was the studies included in that review, including 2 of our own here from UC San Diego. So why does this association occur? There are several hypotheses. One is that people with orthostatic hypotension and Parkinson's disease that have cognitive impairment have a worse kind of Parkinson's disease that's more aggressive or more malignant, affecting wider regions of the brain and the brainstem, more aggressive pathology. A second hypothesis is that these repeated episodes of low blood pressure cause ischemic damage to the brain over time. And the third hypothesis is that there's some combination of these factors. So if either of these latter 2 theories are true, then by treating orthostatic hypotension, we might be able to improve cognition. So I'll talk briefly about my research, focusing mostly on the Career Development Award project. That is one Michael mentioned already, the positional effects of blood pressure on cerebral dynamics and cognition. So the problem is that it's hard to study what happens in the brain in different positions because most of our traditional neuroimaging modalities require the person to be lying down, for example, in the functional MRI. And so it's hard to tell what happens in the brain blood flow when upright using traditional neuroimaging techniques. So for this study, we're using functional near-infrared spectroscopy, which Michael mentioned already, to study the brain blood flow in different positions and during cognitive testing. So I'll just talk briefly a little bit more about this technology. This is a non-invasive wearable neuroimaging technology. Michael showed a picture, I'll show another picture. It consists of different probes that emit and detect light. And this light penetrates through the skull to the superficial regions of the brain. And those sensors and detectors measure changes in concentrations of colored molecules in the blood, so that oxygenated hemoglobin, that is the blood molecules carrying oxygen to the brain, are a different color than the molecules carrying deoxygenated hemoglobin away from the brain. And so when the brain is active and using resources, when someone's concentrating or participating in a cognitive task, there's more oxygenated blood going to the brain and more deoxygenated blood going away from the brain. So using these sensors, we can measure those changes in the brain blood flow. This is, again, what it looks like. The advantages are that it's portable. You can walk around with it. We can do it on the tilt table, which we'll show you later. It's fast to set up, and you can use it even in the home environment. It's expensive, but a one-time cost, and it's reusable. The disadvantages for this technology are that it can only measure the superficial brain blood flow from the outermost region of the cortex, and it requires the specialized equipment. This is what the whole setup looks like. So this is a participant in our study on the tilt table, wearing the FNIRS cap with the continuous blood pressure monitor and then doing the cognitive testing in the different positions. And then just briefly, I'll show some preliminary results from the study. So we compared people with Parkinson's disease with orthostatic hypotension and without. And we found that those with orthostatic hypotension had worse verbal fluency when upright compared to when laying down, which is what we expected based on prior studies. We also found that looking at the FNIRS data, we found that people with orthostatic hypotension had a greater reduction in the deoxygenated hemoglobin. So they're using more cognitive resources, but they're still doing worse on these cognitive testing. Next, I'll switch gears and talk about the ultrasound blood pressure monitor. Michael, did you talk about this one already? Okay, so this is new, so I'll just spend a little more time. So the problem we're trying to solve with this technology is that people with orthostatic hypotension have these rapid, dynamic blood pressure changes that are often hard to detect because they happen quickly. They happen when people change positions, and blood pressure is fluctuating all the time. So it can be hard to capture these at home. And so orthostatic hypotension, low blood pressure on standing is often under-recognized and undertreated, which may have harmful long-term consequences. So the objective of this project is to validate a new device that is an ultrasound blood pressure monitor to measure the blood pressure using a patch-like device that can eventually be hopefully used at home and replace the need for these regular blood pressure measurements that we use with a standard equipment now, which doesn't accurately detect these rapid dynamic shifts in blood pressure. This is the data from our study. We enrolled here at UCSD 85 people, measured their blood pressure lying down, standing up, and then lying down again 30 minutes later to show that the device was stable over a period of time. And we found that the test device, the ultrasound blood pressure monitor, was very close, within 2 to 4 millimeters of mercury of the standard way of measuring blood pressure. That's using this inflatable cuff and stethoscope. So just to show that the device was accurate, at least in the short-term setting, we're now validating a smaller, more portable form of the device and going to be looking at it over a longer period of time. Next, I'll talk again briefly about the levodopa biosensor study that Michael mentioned before. The problems with levodopa, so works well for many people, but the medicine itself has various challenges, and that includes personalized dosing that's different from person to person. We base our treatment of symptoms primarily on patients' self-report and a brief snapshot of the clinic visit that we see them in the office, but this might not represent what's happening throughout their life on a day-to-day or hour-to-hour basis outside the clinic. The levodopa dosing depends on each person's symptoms, their lifestyle, how long they've had the Parkinson's disease, what kind of symptoms they have. Levodopa's action is very short. And the way that we currently have to measure levodopa levels is impractical. It involves drawing blood, sending it to a centralized laboratory, waiting a couple weeks for the results. And so we currently cannot use the standard method to measure levodopa level in clinical practice. The therapeutic window often narrows as people live longer with Parkinson's disease. The effect can become more unpredictable. And this is just a representative chart of someone that has motor fluctuations. Each triangle represents taking levodopa, and then the y-axis is the levels of levodopa, and you can see that the levels might be erratic or unpredictable. I think this looks like a roller coaster, and that can be what some patients feel like when they take levodopa. It's unpredictable. They don't know what's coming next. And so to try to improve personalized management of Parkinson's disease using levodopa, we're working with the bioengineering team here at UCSD. We've been working together for the past 7 years or so. Dr. Van and Dr. Wang are heading this project to develop a minimally invasive levodopa sensor. And we're using finger-pricked capillary blood, sweat, and then the interstitial fluid from underneath the skin. And we hope that this eventually can be used for at-home levodopa level monitoring that could improve disease management. Just briefly, we have some preliminary data. We have published this capillary blood showing in red the levodopa levels that peak, usually about 30 to 40 minutes after taking levodopa at time 0. And then motor performance in black. So the lower the score, the better the motor performance. So we can see that it's still, in some cases, unpredictable, but there seems to be a pattern where when the levels go up, the motor performance gets better. So we're using this technology to hopefully understand more about why motor fluctuations happen and how we can get ahead of that curve. And then the sweat, Michael mentioned already the CNN story that you can go to learn more about this technology. We're also looking at levodopa in the sweat and currently recruiting for testing a continuous sweat sensor for levodopa level monitoring. And then last, just briefly, my other project is using non-invasive sensor technology to better characterize tremor disorder. So tremor is a rhythmic oscillatory movement, involuntary, and usually we base our diagnosis of tremor just by looking at the movement. But as Dr. Coughlin will talk about soon, there are emerging biomarkers that we can also use to help diagnose tremor and other movement disorders. But even then, it might be difficult. There might be more than one syndrome happening at the same time. And so just by visual observation, some tremors might be hard to distinguish. So we use this non-invasive sensor technology to help refine the diagnosis of tremor. This is what the setup looks like. It's sensors on the arms and other sensors on the back of the hand to measure movements. And this is a way we can objectively characterize the movements to better diagnose the tremor. This is not necessary for most people with Parkinson's disease, but can be helpful, again, if someone has more than one tremor type or overlapping symptoms. And so we recently submitted a manuscript on this to illustrate how this can be helpful clinically. So on the left side, these are different diagnoses in 31 people that were referred for this study. And many of them had multiple diagnoses. That is, the referring providers weren't sure what their underlying diagnosis was, and there were various possibilities. So after doing these electrodiagnostic tests, we were able to refine the diagnoses in most of the patients. And in the majority of people, it narrowed the diagnosis so that the clinicians could be more certain what the diagnosis was and change therapy in about half of people, which could include starting or adjusting medications, undergoing surgical procedures, or avoiding surgical procedures that were not indicated. I just want to say thank you to my mentorship team for my career development award research and to the Movement Disorder Center and all our clinical coordinators. And my email's here if you have any questions or comments or are interested in participating in any of these studies. Thank you for your attention. Are we doing questions now or, okay, I'll take any questions. No, I had lots of questions for Michael. No one has any questions? Yes.
I understood that DOPA, once it used to be to take as little as you can because of the prognosis of the disease. But lately I've heard that that's not true and you can take more because it doesn't interfere. So I'm not sure if it's the right thing. I'm doing it very simplicity, but did you understand my
I
question?
think make sure I understand. The question is about minimizing use of levodopa and whether you should try to take as less as possible.
Yes.
Okay, yes, I think it is a outdated and a myth that you should wait to start levodopa to avoid dyskinesias or motor complications. If you wait to start levodopa, that does not decrease the likelihood of developing dyskinesias. I usually would recommend to start considering medicine treatment if you're having symptoms that interfere with your daily life, hobbies, or activities. I think my personal practice is to use the least amount necessary to treat the symptoms adequately. So there's a balance, but I don't believe in holding off on taking levodopa if I think it would benefit someone and improve their functional status.
That's part of the question, but other question, because I understand that as you take it, as the disease progresses, then a certain time the levodopa less affects the patient.
I see. Okay, that's also a myth. Over time, people will require more levodopa, but not because it loses its effect per se, but that after years of losing more and more dopamine, you will need more medicine to replenish the dopamine that is lost. So over time, yes, most people do require more frequent levodopa, higher doses to treat the motor symptoms. But if you waited to take it, you would still likely need more to have that same effect over years. Did that answer the question? Yes.
So will people develop a tolerance to levodopa? Is that a possibility?
No, people don't develop a tolerance to levodopa. Other questions? Thank you.
Format it however you'd like.
That's all good. I'll just change it over to the presenter mode, I guess. Sorry, it's all stuff in the way. That's better. All right, can you guys hear me okay? Wonderful. Thank you for the thumbs up. Thanks for coming in today and thanks for the invitation to come talk. My name is Dave Coughlin. I'm also one of the movement disorders neurologists who works here anyway. I see patients and do a fair amount of research around the campus on various things, including Parkinson's disease, and some other hats that I wear these days as I help to run our fellowship training program in movement disorders. And I also run our Alzheimer's Disease Research Center's neuropathology core as well. And we're going to talk a little bit about some of our research projects lately, both stuff that's happening here at UCSD and also within the broader context of the Parkinson's community as well. This is my research funding, mostly through the government anyway, but we have received in-kind funding from a company named Amprion. They basically have paid for supplies to help us collect some of the samples that we're helping to use to develop certain new biomarkers to help basically create a Parkinson's disease test. So I kind of want to bring this back to the patient experience. I think that almost everybody has this experience where they come to one of our offices and we as doctors do what we usually do. We talk to people, we take a history, hear about what's been going on over the last several years. We do a physical examination anyway to assess for things like tremor or stiffness or slowness and other features too. And at the end of that, just talking to people and doing the exam is when we usually render a diagnosis and say, hey, I think you have Parkinson's disease anyway. And for something that has such weight anyway, it's always felt a little bit difficult anyway to rely on some of these measures, just talking to people in the physical exam. It's still a very powerful tool, and I don't think that we'll ever be able to replace it. But that's usually where a lot of this will end for people with pretty classic symptoms. They might not need a lot of extra testing. Sometimes people will get an MRI ordered. They're usually normal in people with Parkinson's anyway, or they just have regular age-related changes. Sometimes people will get a DAT scan ordered anyway, which is a sophisticated type of PET scan. But to be honest, they don't always get done, and they're not always needed, to be honest. And they're not even perfectly specific for Parkinson's disease. So sort of the question is, how do we augment our kind of classical approach of taking a history and a physical exam to provide objective evidence of what's going on, especially early in the disease where sometimes there's added uncertainty? So how accurate is just a clinical diagnosis of Parkinson's when you go to see your doctor? It's pretty good, but it's pretty good if you've known the patient for several years, usually at least 5 years anyway. Also, you're more likely to be right about the clinical diagnosis if the person responds pretty well to levodopa therapy. I say temporarily because a single dose of levodopa is 5 or 6 hours for most people anyway. Although, as we were talking about just a few minutes ago, the benefits are quite sustained over many years, if not decades. And also, if somebody has developed after several years motor fluctuations or extra wiggly dyskinesia movements anyway, which is, again, usually happens after several years, if that happens, you're also very likely to be right about your clinical diagnosis. But your clinical accuracy is actually a lot less earlier on. In some publications, it would suggest that we're only right about 50% of the time if we've only seen the patient once, especially if they're older than age 80 or so. And especially if there's other sort of what we would call sort of red flag or unusual symptoms that have happened early on in the condition, be it early falls, early memory problems, maybe freezing of gait, the little stutter steps, like when feet get stuck to the ground, are a little unusual to happen earlier in the disease. So it's pretty variable. Now, so what do we really mean about the accuracy of a clinical diagnosis? Now, ultimately, for most people, what is happening in the brain is that there are these accumulations of a specific type of protein called alpha-synuclein. We all have it. It's all supposed to be there anyway. But in Parkinson's disease, that protein gets misfolded and forms these little tiny balls called Lewy bodies. And they seem to spread throughout the brain in Parkinson's disease and other conditions in a fairly typical fashion. And up until recently, we've only been able to see them, so to speak, at autopsy for people who have donated their brains to science, where we've done some special things to it so we can actually see these things under the microscope. However, in the last probably 6 or 7 years, we've actually come a long way with a couple of new sets of tests that have the apparent ability to most likely identify problematic alpha-synuclein in live people. You don't have to wait until autopsy anyway, it seems like. And there's 2 sets of tests that are getting developed still. One is a spinal fluid test called the alpha-synuclein seed amplification assay. And another is a skin biopsy test, where you take small 3-millimeter punch biopsies from the shoulder, right above the knee, and right above the ankle. And you actually see little bits of alpha-synuclein, little bits of this problematic protein in the nerves. So how accurate is the spinal fluid test, which is the alpha-synuclein SAA test? This has been under development for at least 8 years, and the answer is it's really accurate, actually. And this has been recapitulated across multiple laboratories and platforms in a lot of different populations anyway, in this country and in other places. How accurate are the skin biopsies? I would say there's a lot less that's been published on the skin biopsy so far. We're trying to help push that forward a little bit anyway. And a lot of the skin biopsy work has been done across, compared to clinical diagnosis without the benefit of autopsy validation so far. So a little bit more to go there. Our group actually was among the first to help validate the spinal fluid assay using people who had donated brains to our brain bank anyway. And this really helped in so much as we can understand how accurate these tests are in living people. And what we did basically was took old spinal fluid samples anyway and compared it to what was going on in the brains of these people. And we found that the spinal fluid assay was extremely accurate to detect alpha-synuclein pathology if it had reached a certain point, if it had reached what we call limbic or neocortical stage disease, over 98%. And that did not matter what your doctor called you during life. If your doctor was unfortunately incorrect and said this was Alzheimer's disease or this was progressive supranuclear palsy, didn't matter. As long as the synuclein was there, they could pick it up in the spinal fluid. We've also gone on to sort of start pushing the envelope to try to see if there's any relevance for some of the spinal fluid testing in predicting who is going to get Parkinson's. For the last several years, the community has had a growing understanding that there are some clinical scenarios like losing one's sense of smell or acting out the dreams that sometimes precedes a diagnosis of Parkinson's, sometimes by many, many years. And when we've gone to go test some of these synuclein biomarkers in people who don't have Parkinson's, but we feel like are at risk for developing, A pretty high number of them also have synuclein pathology that's already started. This was data that was derived from the Parkinson's Progression Marker Initiative study, which is a very large natural history and biomarker study that's been going on for the last 15 years, and UCSD has been participating in it since the beginning. And what these curves are meant to show is that for people who have REM sleep behavior disorder or have lost their sense of smell, if they have a positive synuclein test from the spinal fluid, they are much more likely to go on and get Parkinson's in the next 4 or 5 years or so than those who have negative tests. And the graph at the far left that have 3 curves anyway is actually meant to show that the people who have the fastest seeding reaction, the most active synuclein aggregation, are the most likely people to get Parkinson's the earliest anyway. So we're starting to create better models anyway to start predicting who is going to get Parkinson's in the next couple of years, and hopefully use that knowledge as a platform to start intervening earlier, possibly before the disease technically starts, before people get stiffness, slowness, and tremor. There's a lot of overlap between Parkinson's disease and dementia with Lewy bodies anyway. And some people think that they're sort of sides of the same spectrum. I think that is a very much open to debate thing, but dementia with Lewy bodies also has alpha-synuclein pathology at autopsy as well, anyway. And our group, in conjunction with the Dementia with Lewy Bodies Consortium, has started investigating how synuclein biomarkers work in dementia with Lewy bodies. And this was all these publications, by the way, are publicly available and anybody can download them at this time anyway. But this was a group of people who, pretty good physicians at big hospitals anyway, had said, hey, I think this person has dementia with Lewy bodies. We only ended up finding that there was synuclein positivity in about 70% of them anyway. So the clinical diagnosis is not perfect, especially for dementia with Lewy bodies. We went on to ask, what is it that's different? What is it about the people who were diagnosed accurately versus those who were diagnosed inaccurately? And the single greatest clinical feature was smell loss. If somebody had lost their sense of smell, they were over 18 times higher of having synuclein pathology on their spinal fluid testing than those who were able to smell normally. And we did this effectively with these little scratch and sniff tests. You give people a booklet and they scratch a little thing off and you smell the little scratchy thing and you say, hey, was the thing that you just smelled, was that chocolate or was that grass or was that gasoline? So we have ways to measure this now. So smell testing is actually a pretty darn good proxy for synuclein pathology. But, in my work in neuropathology, we have to contend with an uncomfortable truth, which is that for most people, they don't have just one thing going on. When we start doing these autopsy studies, most people over the age of 70 have some degree of Alzheimer's pathology. That may or may not result in memory impairment, but all of us start getting a little bit of amyloid anyway when we're 60, unless you're very genetically blessed anyway, it seems like. Now, the question that we have often asked ourselves is, does it matter anyway? So in Parkinson's disease, if people have both Parkinson's disease and some Alzheimer's disease co-pathology, they seem more likely to be older when they start getting the condition, have less tremor, be more stiff and slow, and probably have a faster rates of cognitive decline and time to dementia. They might have specific things that are a little bit harder for them in memory and thinking, specifically having issues with naming objects or recalling recent events. In dementia with Lewy bodies, the presence of Alzheimer's disease co-pathology is also actually associated with a lower likelihood of having problems like hallucinations anyway, too. And this knowledge has actually been integrated into our pathological assessment of dementia with Lewy bodies and Parkinson's as well at this point. Our group has also worked with some longitudinal stuff looking at the influence of Alzheimer's disease co-pathology in people who have dementia with Lewy body diseases, with the red lines and dots indicating people who are just synuclein positive, and the orange are the dots for people who have both. And the people who have both tend to have this faster decline in memory and thinking, and probably a slightly more aggressive course as far as their movement symptoms go, where they seem to get worse a little bit faster also anyway. One other thing that we do in the lab here is we are employing more modern ways to measure neuropathology directly from brain tissue using sophisticated image analysis work, and we're starting to dabble a little bit in artificial intelligence stuff anyway. And this is basically better ways to quantify what is going on in the brain anyway, to basically count your Lewy bodies or show how much Alzheimer's pathology there is there. And there's some examples of tau neurofibrillary tangles, amyloid beta plaques, which are the hallmarks of Alzheimer's disease, and Lewy bodies, of course, which we've been talking about for a little while. And we can use the image analysis work anyway to make better maps, so we can tell exactly where the brain pathology is and how much is there. And this actually helps us create different hypotheses of where the disease might start and how it might spread throughout the brain. And also, one thing that I particularly enjoy doing anyway is using those neuropathology assessments to help develop tests that we can use in people. And how do we associate the burdens of neuropathology with things like MRI? What does it mean to have an MRI where there's a little bit less volume of a certain area, or certain areas a little bit shrunken? We've used it to help develop PET tracers anyway as well, and even like try to figure out what kind of spinal fluid protein levels are necessary to help diagnose some of these things. So we tie the neuropathology back to the tests that we're trying to develop to use for people. And probably one of the last features, which I think is something that I think is potentially quite exciting and hopefully will pan out anyway, is we talked a little bit about seed amplification assays, which is a way to measure seeding activity from spinal fluid as being a very accurate way to detect Parkinson's type synuclein pathology. You can actually measure seeding activity directly from brain tissue. This is something that hasn't been possible and hasn't really been done before, but we're starting to try to leverage this observation to try to figure out, again, different patterns of pathology, figure out where the earliest stages of changes are happening, and if there are different patterns that might be different from person to person. It's a kind of a way to try to start putting together our own experiences, which is that Parkinson's patients are very, very different from one another. Some people have lots of different types of symptoms, and other people are spared of certain aspects of the disease. And what is the biologic basis of that? Is it actually just that different things are happening in the brain anyway? And this is going to be a new way to start asking that question. So we have a number of course, the work continues despite recent occurrences. The work will continue. So we're trying to do some work validating the skin alpha-synuclein biopsy work against neuropathologic findings. Anyway, we're starting that project up very soon. And we're also trying to help develop skin and blood-based seed amplification assays. The whole idea being is that even though the spinal fluid test works very, very well anyway, not everybody can get a lumbar puncture, and not everybody wants a lumbar puncture at the end of the day either. But it seems like the same platform, we might be able to get it to work from like a blood test. I mean, possibly. It needs a lot of work, but pretty soon we might have a blood test for Parkinson's. We're continuing to try to understand the interplay of synuclein and Alzheimer's co-pathology, and we're doing this by doing seeding activity work directly from brain tissue using samples from our own brain bank here at UCSD and other partners across the country. And we're trying to better understand the lifetime risk and progression of synuclein pathology. As these tools develop, we're going to start understanding that there are probably more people out there who are harboring synuclein pathology than we would have known otherwise. And it might not be the case that every single person or every version of synuclein pathology is bad. There might be some people who can have a little bit of it and it doesn't cause much problems. So we're going to have to start contending with what are the versions of this that are problematic versus which ones are more benign and we can kind of leave alone. But those are some of the questions that we're starting to ask now. And some of the reasons that we can ask those questions is because we have better tools. So this is sort of the purpose of what I kind of conceive of my own research program is we try to use neuropathology to help understand how novel biomarkers are working anyway, and what the relevance for those biomarkers are, be it spinal fluid, skin, brain scans, or whatever. What do that mean is happening in the brains of people? Why is this important? The purpose is so that we can develop tests, that we can start integrating this into clinic, so that we can start having a regular doctor's visit with a history and physical exam, but then there's next steps. Saying, I think you have Parkinson's, let's do some testing. Let's try to figure out if there's actually synuclein pathology there. Let's see if there's anything else going on there, so we can have more sensible conversations with patients about what the future might hold for them, and hopefully also suggest particular disease modifying treatments that help slow things down, stop, or hopefully eventually reverse things. But that is the end of my talk. I wanted to leave lots of time for questions. I did not get a chance to get into genetics, but I'm happy to talk about any questions you guys may have. Yes.
You know, all of you talked about a lot about Parkinson's disease. Is there any treatment for tremor people?
Tremor in Parkinson's disease or just tremor in general? Okay. So for those who might be on Zoom, the question was, what kind of treatments are out there for tremor specifically? It depends on what type of tremor we're working with anyway. And I'll just say this for these guys, but for tremor in the setting of Parkinson's disease, typically levodopa is fairly effective, although we often have to push it to higher doses than what's needed to control other symptoms anyway. There are other conditions like Parkinson's is not the only thing that causes tremor. There's other things out there. The most common thing being essential tremor, anyway. And essential tremor, we have, a couple of medications that work pretty well, typically propranolol and primidone anyway. They are not perfect. Some of them have some side effects, and probably only about 60% of people will respond adequately to those drugs anyway. There are some second line agents. They honestly are more likely to cause side effects and less likely to help. So I would say for essential tremor, we often are talking about surgical options a little bit earlier than we do with Parkinson's anyway. Things like DBS, which is effective for tremor and essential tremor, and even some newer surgical options that have been on the block for the fewer number of years, like focus ultrasound. So yes, there's absolutely many treatment options. We take care of a lot of people with essential tremor here as well. It's part of movement disorders. Well, basically any of us do. I think essential tremor is at least 30 to 40% of the people that I end up seeing on a given basis. And so me, Dr. Longardner, Dr. Mulligan, Dr. Lessig, Dr. Hess, and we have 2 new faculty who are going to be joining us pretty soon, Doctors Lin and Fuentes also. So it'll be easier to get a new patient appointment probably in the next few months. Yes. Yes. Synuclein has been an attractive target for trying to prevent or slow down Parkinson's for many years. We've had some failures on that front so far, but there's still a number of things going through the clinical trial pipelines. As far as like big buckets anyway, there are some groups that are still trying to develop immunotherapy, basically giving people a big bag of antibodies that help tag the bad alpha-synuclein and help your body clear it out anyway. Some more data should be coming later this summer about what they're going to do about one product that's going through the pipeline, we think. Sorry? Not enrolling right now, but if they move forward with the phase 3 as they have intimated that they might, we would be very interested in being a site. There are some other work in small molecule domains where they're basically trying to design little molecules that stop the synuclein protein from misfolding. So it just stays in sort of its normal form. Yes.
If beta blocker is contraindicated in treating the essential tremor, what are your thoughts about the high intensity focus ultrasound?
Ooh. Loaded question. So the question is like, if we have to, what do I think about focus ultrasound in the setting of essential tremor? So that's been FDA approved for a couple of years now anyway, although there's a lot less experience with it than there is with deep brain stimulation, because deep brain stimulation has been around for close to 30 years at this point. So high frequency focus ultrasound, the way it works is basically they ask people to shave their heads and you are focusing 1,000 some odd beams of ultrasound energy into a particular part of the brain. And kind of like a microwave, it actually burns a small hole in the brain. They do this very willfully to do this in a specific area that interrupts the tremor network. Now, That sounds like it sounds pretty crazy. Obviously, in medicine, we do that kind of thing in different scenarios, like gamma knife for cancer therapies, proton therapies, things like that. And this is ultrasound energy, so there's no radiation, so no problems there. But it is irreversible. You're making a hole anyway. DBS is adjustable. Focus ultrasound is not. You do get the results immediately with focus ultrasound anyway, or with DBS, it's a little bit more of a process trying to get the programming right anyway, usually over a couple of months after surgery. This is a changing landscape. Only recently have people started to get comfortable with doing both sides. About 2 years ago, we used to have to say, if you want to do focus ultrasound, you got to choose. You got to choose if you want the tremor to be good in your right hand or your left hand, but they won't do both. Some places are starting to do both sides, but they usually ask for a minimum waiting period of 6 months before they'll do the other side.
Do you provide
Not yet. We haven't done it yet. There are 3 groups in Southern California that do have rigs to do this. Sharp Healthcare has a focus ultrasound rig, so does Hoag Hospital in Orange County, and UCLA has the longest running experience with focus ultrasound so far. Yeah. Yes.
Comorbidity, that's the word, I have post-polio syndrome,
Mm.
and that concerns, and the VA, I'm going to VA at the end of the month. I'm concerned about shadow symptoms that can't be defined as one or the other. I was involved with toxic water and plant lagoon, so I've gone through all that toxology, and I've been through testing at UC San Diego. I go to the clinic, which is a brand new satellite clinics at the end of the month. But with this kind of testing and therapies, is there a conflict between those two conditions?
So the question for Zoom is, I guess kind of like, how do you sort of tease some of these things apart when some physical symptoms and different neurologic conditions may overlap, and specifically post-polio syndrome? So that's going to be part on your doctor anyway. Polio affects different parts of the nervous system than Parkinson's disease does anyway. There can be some testing that'll help tease them apart. DAT scan could be potentially useful depending on what that person thinks anyway, to really hone in on where some of the damage is. But there may be some question at the end of the day about what symptoms are made worse because of the polio syndrome and what symptoms are made worse because of Parkinsonism. So you're right, this does offer a challenge. We have some tools that can help tell us a little bit about it apart, but still it'll be a little bit of conversation between you and your doctor about what's what anyway at the end of your visit.
Condition like gait, like you're walking, okay, which one is it? And no one seems to, I mean, there's not a lot of this going around anymore, so. Okay, thanks.
It's tricky. Although admittedly, polio and post-polio syndrome should cause different changes in walking than Parkinson's should, but that's really up to the eye, actually, and then the experience of the neurologist who's seeing you anyway, so we'll see.
Is post-polio syndrome common with people with Parkinson's?
No, it's a sort of a separate thing that happens after people have a childhood infection of polio anyway, and which, so they're separate anyway. Yeah, it's one of those things that was very common, but like you said, haven't seen much polio anymore, thankfully, because of good vaccine efforts anyway.
Been diagnosed with
Uh-huh.
a couple of cancer.
Oh, 100%. And since you bring it up, it's kind of a good leeway into how common is Parkinson's versus how common is post-polio syndrome. And this is something that kind of bothers me and bothers many of us, is that Parkinson's is really common. We think it affects like 1 in 100 people over the age of 65. That's a big number. And that number is going up. And it's going up faster than we would expect it to, given the general aging population. No, people don't understand exactly why, but it is a definite concern. Question in the back.
Using the alpha synuclein assay, have you ever looked at it and using that assay alongside like genetic screenings of risk alleles to maybe increase a correct diagnosis? Happen with that?
I think it depends on what you are talking about as defining correct, actually, in some ways. But if your goal is to predict synuclein pathology, the SAA test by itself should be very good. The nuance that you are sort of hitting on, this might not be exactly what you're talking about, but this is an important point, is that there are versions of Parkinson's disease that are mediated by genetic changes. They're not terribly common, but they're out there anyway, but where there is no synuclein pathology, but people still have stiffness, slowness, tremor, respond well to levodopa, respond well to DBS. Some of them are pretty darn indistinguishable, but it's due to a genetic change that does not cause problems in synuclein. Those people will be synuclein negative on their spinal fluid testing. So I think that you can't hang your hat entirely on this new technology anyway. You still have to use your good clinical judgment. And if I had somebody who like looked all the world like Parkinson's anyway, was negative on their synuclein test, no red flag symptoms, I would highly consider genetic screening to see if they're one of those people who had a genetically mediated form of Parkinson's instead. Yeah. Yes.
I'm beta blocker and using something ultrasound, something laser. I didn't hear third one word you said, ultrasound.
If we're talking about essential tremor,
Yeah.
that was in the realm of, yeah, that's okay. It's those were the two main surgical approaches to treating essential tremor are deep brain stimulation and focus ultrasound. Yeah.
Is there a specific line that patient crosses it where it becomes Parkinson?
A specific line.
Yeah, I mean, patient has it, this one doesn't.
This is
How would I know if I had it?
How would you know if you have it? So this is actually something that's starting to be debated. And actually, I wouldn't say started. The debate's happening, and it's actually pretty hot, and people feel pretty darn strongly on both sides of the aisle. And the question is, do you define Parkinson's disease by the physical symptoms? Do you define it when people get stiffness, slowness, and tremor? You got a problem, looks like Parkinson's, that's when the disease starts. Or should you start defining it by the underlying pathology? Saying like, hey, you've got synuclein here. We can see it on the spinal fluid anyway. Maybe you've got a little bit of smell loss or a little bit of REM sleep behavior disorder, but you don't have that other stuff. You don't have tremor, stiffness, slowness, but we can see that there's something going on. Is that when we should start saying Parkinson's is starting? When the pathology is starting before some of the main symptoms happen? That's the argument. Anyway, that people are having, and there are very loud voices on both sides. Anyway.
Thank you for not answering my question.
Well, I mean, you asked the question. This is what we're fighting about. Literally every conference that I've been to for the last 2 years, it seems like has some session where you got people are just all sorts of upset about it. I think that the new tests like offer a very, very distinct possibility that we can actually do the latter thing. Start identifying the pathology before it happens. I would love to see a little more refinement so that we could really say this person, the analogy that the people who argue this use all the time is cancer. It's like cancer doesn't start when you feel the lump. Cancer starts a lot earlier anyway. And we shouldn't wait until people feel lumps to start treating cancer, right? Okay, obviously, yes. Okay, well, that's the analogy only goes so far. I usually respond to that. Are there versions of cancer that are like prostate cancer? Is there a version of like synuclein pathology where there's we can just watch it, it's not going to do anything. Maybe it reaches a certain point and there's like, okay, now it's at some certain degree. Now we got to do something. Now we got to treat it with drug X or Y anyway. I think those are just ideas of how things could develop anyway. I think we have better tools to get us into some of those early stages that weren't available a few years ago. But I still think there's a lot more work to do to really figure out like what version of the synuclein is going to be a problem and which ones are not such a big deal and we can kind of ignore actually, or just monitor anyway. That's my personal take on it so far anyway, but big asterisk because this is getting done right now. We're still trying to figure this out. Yes.
The Parkinson causes numbness and tingling sensations in the hands and feet.
Oh, good question. So it's not usually a big part of Parkinson's anyway. I would say that there is some suggestion that there can be what we call small fiber neuropathy that's associated with some versions of Parkinson's anyway. It's usually not that bad, and it's usually not to the degree where people start telling us that they have numbness and tingling anyway. The thing about neuropathy in general is that there's about a million things that cause it anyway. And Parkinson's is kind of one of them, but if it is, it's usually very mild. And if somebody came to me in our clinic and said, I have Parkinson's and I have really bad numbness and tingling, I wouldn't stop and say, oh, it's just the Parkinson's, don't worry about it. I would probably try to figure out if there's any other reason. Diabetes, pinched nerves, lots of other reasons anyway. So your answer is yes, but I wouldn't stop there. Sure. Yeah.
I understand your smoothly and assay tests are helping you determine how much of it is or is it present, at least. What point in time, this is a hypothetical, what point in time do we figure out how to slow down or eliminate the Lewy body progression of?
Yeah.
asymmetrical?
I would say that that's long been a goal anyway, and those efforts started, many, many years before this test got developed anyway. I think that this set of platforms helps in so much as it makes sure that people are diagnosed fairly accurately, or at least that you have pathologically homogeneous populations getting enrolled into clinical trials, which is a long way of saying it doesn't really make sense to test a synuclein antibody in somebody who doesn't have synuclein anyway. We weren't able to do that before a few years from now. Now, people are still trying to work on synuclein anyway. Like they didn't start working on this like last year anyway. It's been going on for a long time. And it still seems like immunotherapy and small molecule work is probably the biggest thing, but synuclein is also not the only target. It's not the only thing that people are trying to fix to try to slow down, stop, or reverse Parkinson's anyway. It's been an attractive target, but it's not the only one.
Is there any advancement in stem cell application?
Man, how much time do we have? So stem cells is interesting too, because it's having a little bit of a resurgence recently. So there's a longer history of stem cells that us as a community anyway did some stem cell work in the early to mid 2000s. These were mostly fetal mesenchymal stem cell grafts. And for some people, they worked okay. And for some people, they really didn't work well. Yes. People had really bad dyskinesias in some cases anyway, and the field kind of got away from stem cells for a while. There's 3 or 4 companies and groups that are starting to try it again with sort of like next generation stem cell therapies. Some of them are donor cells, and some of them are ones that would be grown up from your own stem cells, basically taking a skin sample and growing up your own. They are in early clinical trials. The procedures that will be necessary to implant them are highly invasive. I think sometimes people think about stem cells and, oh, it's this like natural holistic version and everything. But what has to be done is a brain surgery where they, go through the skull and actually put a needle in it and implant the stem cells into the deepest parts of the brain where Parkinson's affects anyway. And then they kind of like leave them there to hopefully let them grow and make the right connections, not make too many connections while they're growing. So it's early days, but it's I can think of at least 3, maybe 4 big groups that are trying this again, and a couple of people have been implanted at this point anyway. So we're trying to see how it goes. I will say that one of the things, if you're not doing your own stem cell growing up thing and you're getting a donor set of stem cells, people need to be immunosuppressed, kind of like they've had a transplant anyway. Not quite that much, but again, you need something to tamp down your own immune system so you don't attack your brand new stem cells that you got anyway. Correct. Yeah. So there's, it's going to be a heavy lift with a lot of, a decent amount of risk associated with it. But yes, we are getting back into the stem cell world again.
Extract your own stem cells. They use your stem cells.
Yeah, there's one group doing that.
Could be determined that there are no wild alpha-synuclein proteins running around.
Yep. And if you really want to get into it, back in the early 2000s studies anyway, when some of those people who had gotten the stem cell grafts went and donated their brains when they passed away, there was synuclein pathology in the grafts, which doesn't sound like it was necessary. I don't know. We weren't expecting that. We really weren't. It would be kind of like a 5-year-old brain getting Parkinson's. It was clearly spreading into the grafts anyway. So that makes a lot of people think that stem cells maybe will kind of turn back the clock a good bit anyway at best, but might have to be paired with other therapies to help stop the spread so we can protect the graft after it gets implanted. But again, this is all very hypothetical and work that's happening right now. Yes, Marty.
So my understanding is we're replacing double neurons with neurons, right? How is the synuclein address? Is that still happening?
It's still happening. It would still be happening. You'd be kind of giving people back more brain cells anyway, but if synuclein continues to spread, it would still do its thing. So we don't know exactly how that all goes together yet. But again, it's happening. We will hopefully see results in the next, couple months, maybe a year or so from some of the phase 1B stuff and see how it goes. This is an exciting time. We got some stuff that we're working on. Yes.
Disease is congenital.
Also a good question. So when I usually start this talk, the question is Parkinson's disease congenital, by which I think you mean genetic. So the vast majority of Parkinson's is not genetically mediated. And if you want numbers, our best guess anyway is that it's probably about 88%, 85%-ish is not genetic. There's no single gene that causes it. So yeah, 12 or 15% of people with Parkinson's, yes, there is a genetic reason. Oftentimes they will know that it runs in their family anyway, just because mom or grandma and a bunch of people had it. But sometimes we find those mutations in people who have no family history anyway, depending on the situation. Another big asterisk, which I would be remiss if I didn't mention it, is those numbers, 15, 12%, are based overwhelmingly on white populations. Those studies were done in North America and Europe and have been done over and over again. And we're very sure about that 12 and 15% number in that context. Those numbers might be different in different parts of the world. There are some better efforts happening now in Latin America anyway, and some parts of Asia, but yeah, there's still a pretty big blind spot for certain parts of the world in the genetic landscape of Parkinson's anyway. Should we get some lunch? Yeah.
There's still that big mystery as to those who don't have any genetic.
Yep. And that's the big majority of people with who don't have genetic changes, and whether that's environment, toxic exposures, age, a little bit of both. We don't know all of the factors. It's clearly that different things cause it for different people. We just don't have the whole puzzle solved yet. Yeah. All right.
Thank you, everybody. We have some light refreshments outside the auditorium, a chance to ask some questions. And there's a table set up with our research team. So there's more information, which Michael talked about earlier. We also have Sarah, who's part of our development team. She's a great resource to talk to as well. So please go out and enjoy. We also may try to get a photo. We have an internal for our neurosciences department, a newsletter that goes out, and this is something that we would like to showcase to the rest of our faculty. So if you feel comfortable being in a photo, we may take one. If not, that's fine too. So thank you very much.